Hey everybody, I'm Arash from NorCal SCI. I'm the executive director, and today's webinar on SCI and mental health. This is the recording that you are watching. We missed the first couple of minutes of the presentation live for the recording, so my apologies for that. So I just wanted to take a quick moment and introduce this so we don't just jump right into 2 minutes into Shen's talk here. So the importance of SCI and mental health is so important to everyone who's living with a spinal cord injury. I know I've had my challenges from my own spinal cord injury that was almost 13 years ago. And so I'm really honored and happy and grateful to have Dr. Shen Hayward here presenting the material that you're about to watch. So yeah, the order's a little goofy, but I just wanted to introduce the webinar here for you. And we have a wonderful program. We have some great questions and some other parts throughout the presentation. Can I ask you to just briefly introduce yourself before you dive in to the presentation, Dr. Hayward?
Thank you for inviting me, and it's such a pleasure to be here today.
Thanks.
So, mental health. There we go.
Sorry
Importantly,
about that. Forgot to do it sooner. So better late than never.
better late than never. Absolutely.
Go ahead.
And importantly, mental health is not static, meaning we can all fluctuate along that continuum at different stages of our lives or on different days and even at different moments. This talk will take us along the entire spectrum, from clinical disorders that can impact people with SCI to resilience or bouncing back from adversity to one's pre-injury state, all the way to post-traumatic growth, which would be found at the higher end of that diagram. And now depicted here, this is the biopsychosocial model. It's adapted by Maggie Budd and her colleagues to the experience of living with a spinal cord injury. And what it demonstrates is that the consequences of a spinal cord injury entail much more than damage to the spinal cord. SCI is a physical or biological injury that is tightly combined with various psychological, such as mood and personality, and societal, such as financial and relational consequences. And whereas a static view of living with disability neglects the reality of the dynamic and continual psychosocial challenges over time, this model helps us appreciate a person's experience of disability by considering the dynamic interactions of all the factors that are common for people after SCI. And SCI is a condition requiring lifelong daily adaptations for both the person with the spinal cord injury and those caring for and about them. So before we turn to the actual mental health challenges themselves, I thought it was important to address the why behind them. That is, why do people with SCI experience these challenges? So when it comes to mental health of people with disabilities, research has repeatedly shown that it's not the direct effect of physical or biological challenges that most diminish quality of life. Specific to SCI, neither level of injury, meaning if you're a quad or a para, nor severity of functional impairments, complete, incomplete, is neither of those things are associated with the amount of distress experienced, which suggests that other factors contribute more to psychological distress than the more obvious physical ramifications from the injury. And research shows that it's the effects of living in a society that is designed for and supportive of non-disabled people alone. So from inaccessible buildings and modes of transportation to pervasive employment discrimination, often despite the protections of the Americans with Disabilities Act of 1990, modern societies have been built in ways that often systematically oppress, discriminate against, and stigmatize those who are disabled. And to make this more explicit, here's a quick primer on terms that most of us know, but as a reminder, Ableism refers to disability-based discrimination coming from the assumption that the non-disabled body is better than any other bodily form, and to the social ramifications of that assumption. And ableism can be overt, such as not providing access to someone with a disability, or it can show up in more subtle ways, such as through microaggressions, which are indirect or unintentional discrimination against members of a marginalized group. And importantly, research on this general negativity towards people with disabilities has been documented in many people with disabilities themselves. And this is referred to as internalized ableism or self-stigma. And according to studies, self-stigma appears to change over the course of injury. It's most prevalent during the first 2 or 3 years of SCI, and it usually decreases. However, for some, the experience of stigma often persists over the lifetime. Finally, ability privilege is the series of unearned advantages that a person gains simply because they are not limited by physical or mental impairments, such as not facing job discrimination based on your perceived abilities, or not having the worth of your life questioned, and not being made into inspiration porn. And for those of you who haven't been introduced to that term yet, I can cover that in the Q&A. But most importantly, it's the very stigma about which we're talking that often causes, or most causes, poor mental health. And research has shown that feeling any form of stigma can affect psychosocial outcomes such as social disconnection, a sense of injustice, greater depressive symptoms, reduced self-efficacy, and decreased quality of life. And as depicted in this cartoon, perhaps one of the most pernicious and foundational ableist attitudes concerns assumptions about the quality of life of people with disabilities. Contrary to many assumptions, high quality of life is actually the norm, and this has been shown in numerous studies, from young adults who had lost limbs to those with a life-threatening disease or disability, and most pertinent to us today, the majority of SCI survivors who've been studied see themselves as being better off than most people with or without a disability. But it's important to note that there's a sizable minority of people with SCI who do experience negative mental health outcomes, and we'll be talking about those today. So living with SCI is complicated. And now let's turn to some of the potential psychological consequences of living in an ableist context. And we'll start at the low end of the mental health spectrum. This is -5 to 0, and take a more detailed look at 3 of the most common psychological challenges faced by people with spinal cord injuries: depression, anxiety, and PTSD. And for each condition, I'll discuss what it is, its symptoms, how prevalent it is in the SCI population versus non-SCI population, and what the best treatments are. And I want to note that substance use disorders are equally serious and very common, but in the interest of time, I won't be focusing on them today. So first, depression. So depressive disorders such as MDD, or major depressive disorder, which is one of many, are common and serious medical illnesses that negatively affect how you feel, the way you think, and how you act. And periods of sadness are very normal after SCI. After all, it's a big loss. But there's cause for concern when feeling depressed or losing interest in usual activities occurs almost daily and lasts more than 2 weeks. For a diagnosis of depression, 5 or more symptoms from a list of 9 that's on the screen must last at least 2 weeks, and they have to represent a change in your previous level of functioning. So these symptoms can vary from mild to severe, and they can include the first 2, feeling sad or having a depressed mood, and loss of interest or pleasure in activities. And distinguishing between grief and depression is really important because it can assist people in getting the right kind of help or treatment. So the grieving process after any significant loss is natural and unique to each individual and shares some of the same features as depression. Uh, Both grief and depression can involve intense sadness and withdrawal from usual activities. And although they can coexist, they're also different in really important ways. For example, in grief, painful feelings come in sort of a wave like form, and they're often intermixed with positive memories. But in major depression, mood and or interest are decreased for most of 2 weeks. Another difference is that in grief, self esteem is usually maintained, but in major depression, feelings of worthlessness uh, and self loathing are really common. And then just a quick note on the 5 stages of grief: denial, anger, bargaining, depression, and acceptance. Really well known, talked about everywhere. And they're often talked about as if they are meant to happen in order, moving neatly from one stage to the other. But this isn't often the case. And Dr. Elizabeth Kubler-Ross, who originally developed the stages, developed them actually to describe the process that patients with terminal illness go through as they come to terms with their own deaths, not of grief. And then it was later applied to grieving friends and family. But the theories become really controversial. And that's largely because there's little evidence found for the existence of the stages. And now just a few stats about depression and SCI. Um, Although 1 in 20 Americans, that's Americans who are disabled and non-disabled all put together, 1 in 20 people get depressed every year. It's even more common in the SCI population. It's about 1 in 5 people. And interestingly, more than 25% of people with SCI actually had difficulties with depression before they were injured. And this is important to note because being prone to depression or any other mental health problem can make it harder to adjust to SCI. So if you're in that situation, it might serve you well to have regular mental health services during and after rehabilitation. And a couple of important myths to dispel. First, as I said earlier, injury and demographic factors like age at injury, sex, level of injury, um, all of the things that are speculated about for who has it worse, or who is it easier for to adjust to SCI, none of them have been found to predict depression. So you're no more likely to be depressed with a C4 injury, for example, than a T4 or a T12 injury. Um, Second, and more importantly, most studies have found that only about 1/3 of people with SCI are clinically depressed, while the majority, or about 70%, are not. And these findings negate the common expectation that depression is an expected or inevitable result after SCI. And finally, depression is treatable. And a wide variety of treatments have been proven effective for depression. Some involve behavioral lifestyle changes. Exercise is referred to as nature's antidepressant, for example. Psychotherapy is shown to be very effective. And other treatments involve taking medications like SSRIs. And there's also newer techniques that focus on neuromodulation, which incorporates electrical, magnetic, or other forms of energy to stimulate brain pathways. And examples of that are electroconvulsive therapy, or ECT, and transcranial magnetic stimulation, or TMS. Finally, ketamine assisted psychotherapy, CAP, is a mental health treatment method that involves using ketamine's trance-inducing and pain-relieving properties to help people work through various mental and emotional challenges, and it's been shown to be effective with depression. But I think the takeaway of this section is that depression is not a necessary or inevitable part of living with a spinal cord injury. In fact, most people with SCI are not depressed. So if you are struggling with depression or feeling low for more than 2 weeks, it's important to talk to your doctor because depression is treatable and beatable. And next, we'll move on to anxiety, which is really just a normal reaction to stress. Mild levels of anxiety can even be beneficial in some situations, like they can alert us to dangers and help us prepare and pay attention. Um, and anxiety disorders differ from normal feelings of nervousness or anxiousness. And in general, for a person to be diagnosed with an anxiety disorder, the fear or anxiety must be out of proportion to the situation or be age inappropriate, hinder one's ability to function normally. And for GAD or generalized anxiety disorder specifically, on more days than not, for at least 6 months, uh, a person would need to have excessive anxiety and worry about a number of different events or activities, find it difficult to control the worry, and have the worry cause significant distress or impairment, and have 3 or more of a list of 6 symptoms, including being easily fatigued or feeling restless. So it's a really specific combination of particular symptoms in order to qualify for a diagnosis of an anxiety disorder. And they are some of the most common mental disorders. They affect over 30% of disabled plus non-disabled people at some point in their lives. Whereas when you just look at people with SCI, estimates of around 30 to 45% of people will experience significant levels of anxiety. And there's mixed findings about the timeline of experiencing anxiety post-injury. Some research found that anxiety levels seem to heighten during the initial period of injury, but often decline around 1 year post-injury. Um, but another longitudinal analysis of the emotional impact and coping after SCI found that little changes in anxiety over the course of 10 years. And it's probably because coping techniques were also found to be stable. That is, coping strategies used at week 12 were predictive of clinical conditions 10 years later. But this is a hopeful hint. So if you change your coping strategy, you can change your mental health. And finally, for anxiety, the treatments. So although each anxiety disorder has unique characteristics, most respond well to 2 types of treatment: psychotherapy or talk therapy and medications. And these treatments can be given alone or in combination. One type of talk therapy that's especially effective for anxiety, or considered the gold standard today, is cognitive behavioral therapy, which can help a person learn a different way of thinking and behaving, especially using exposure techniques. Medications, on the other hand, will not cure anxiety disorders, but they can provide significant relief from symptoms. And the most commonly used medications for anxiety are benzodiazepines, which are prescribed only for a short period of time because they're highly addictive. And now the first line is typically antidepressants like SSRIs. So finally, PTSD. And the diagnosis requires exposure to an upsetting or traumatic event. And the symptoms have to fall into the following 4 categories. For a diagnosis, people need to have a certain number of symptoms from each category. Those categories are intrusion, which can include intrusive thoughts such as memories, flashbacks, or nightmares; avoidance, such as avoiding reminders of the traumatic event; and that includes like avoiding situations, memories, or talking about what happened; alterations in thoughts and mood. Um, that can be negative thoughts and feelings about oneself or the world, feeling detached or estranged from others, or being unable to experience positive emotions. And finally, alterations in reactivity, um, like becoming irritable and having angry outbursts, behaving recklessly or in a self-destructive way, or being hypervigilant, or even having problems concentrating. PTSD affects approximately 3.5% of US adults. That's folks with and without spinal cord injury lumped together. But research suggests that the prevalence of PTSD post spinal cord injury ranges from 10 to 40%. And without treatment, the lifetime prevalence of PTSD for those with SCI remains high. Up to 29% continue to report symptoms 30 years after injury. Typically, that's folks who are untreated. And vulnerability to PTSD after SCI depends upon this combination of individual and contextual factors before, during, and after SCI. So some factors before SCI or at the time of the injury that might make one vulnerable to PTSD include history of other mental health problems, family instability, and the perception of not having enough social support. Also, factors leading to vulnerability after SCI are depressed mood, negative appraisals, distress, anxiety, and pain. And also two more psychosocial components, lower income and lower education are also associated with having PTSD following SCI. Finally, the treatments. Many people with PTSD, as many of you might know, find it very helpful to share their experiences and feelings with others who've had similar experiences, such as in a peer support group or in therapy. And there's also a number of evidence-based psychotherapies that are highly effective in treating PTSD. The first is cognitive processing therapy, or CPT, and it's a type of cognitive behavioral therapy designed specifically to treat PTSD and comorbid symptoms. And it focuses on changing painful negative emotions and negative beliefs. Then there's prolonged exposure, which uses repeated exposures to symptom triggers in a safe, controlled way to help a person gain a sense of control over their fear and to learn to cope. And then finally, there's EMDR, or eye movement desensitization and reprocessing therapy for PTSD. And it helps the person reprocess the memory of the trauma so that it's experienced in a different, non-threatening way, using eye movements similar to those in REM sleep, as the therapist guides the patient through questions about the traumatic memory. And medication also can help to control the symptoms of PTSD, not a cure, again, but they can allow many people to participate more effectively in psychotherapy. And finally, other treatments, including like complementary and alternative therapies, are also increasingly being used to help people with PTSD. Those approaches provide treatment outside of the conventional mental health clinic and might require less talking and disclosure than psychotherapy. So examples would be acupuncture, yoga, and animal-assisted therapy. And now we're going to take our first break for questions.
All
And
right.
I'm going to close down. Oops.
I'll go back to your other view. Yeah.
Okay, there we go.
Anyone have any questions so far? You can type them in the chat, you can raise your hand, or you can just come off mute and go ahead and ask.
I know that was a lot of information all at once.
I was thinking too, an entire topic for another time might be, because I know there's a lot of interest sometimes, psychedelic. You mentioned the ketamine assisted therapy for depression, but I know a lot of people are curious about, psychedelics and the role in mental health, and some have experienced them post SCI and some haven't. So yeah, if there's nothing else, I have a question on that too. So, but I want to allow for space for someone else.
It looks like there's one question that might be in the chat.
Oh,
Or
I didn't see it. So if you see it, let me know or go ahead.
okay. Oh, it's a comment directly to me, so I won't share it.
Okay, fair enough.
Yep.
I figured if it wasn't visible that it might come directly to you. So, yep, we'll keep that one private.
Yeah.
Um, I guess on that, Shen, can you just mention a little bit more about the ketamine assisted therapy specific kind of your knowledge, your experience with it?
Yeah, certainly. Definitely a growing and sort of hot area right now. Um, CAP, or ketamine assisted psychotherapy, looks like well, there's several different ways that it is not induced, but that it's administered. I had a client recently who had treatment resistant depression, meaning she had tried like 3 or 4 different types of antidepressants, psychotherapy for years, and still wasn't finding relief from her depression. So she wanted to try ketamine, and she went to a psychiatrist who was qualified to administer it, and he administered it into an IV, which was in her arm, and then which induced a trance of sorts. And while she was in that state, he would guide her back through the traumatic experience for PTSD. And then after the ketamine wore off, she would that have guidance about how to process what she'd experienced. And she found it moderately effective. Some people find it very effective, some people not at all. So there's a really big range. But the one trick about ketamine is that not all insurance covers it. So it's not accessible to a lot of people because it's quite expensive. Um, so the client that I was talking about, her insurance didn't cover it. So she only received it for maybe 5 or 6 weeks, because of the price. But if you're lucky and have one of the good insurance, it's definitely worth something to explore. But typically I would only recommend it after you've been through several rounds of different types of antidepressants, like different classes, like maybe an SSRI and an SSNR, all right, different types, and therapy, because the research would suggest that that's probably the best route, and also the expense.
Yeah. And
Yeah.
I'll be very honest. I have taken part in ketamine assisted, just a one-time thing. I
Oh,
found it very helpful. I also did a session with psilocybin, magic mushrooms,
oh,
well.
interesting.
So separately, again, just one time with each. I found both unbelievably helpful. In fact, the psilocybin session was very difficult, but it was a really profound impact on my mental health. So yeah, so that's separate thing for another time. We can talk about that more later or something. But I wanted to actually ask one other quick thing. We didn't really mention this at the beginning, and maybe you're going to go more into it in your identity story, but I don't know if you mentioned you have a spinal cord injury yourself. So
Mhm.
I'm not, yeah, did we
Yeah,
already
I don't
do
know if
that?
that
Yeah.
was
Oh,
mentioned. Yeah, but they'll definitely go into that when we
yeah.
get to the identity section and talk a little bit about how it's impacted me
Yeah.
and what I've done with it,
Good.
so to speak, how to transform it into something
So
wonderful.
good. No, I just want the audience to know that you're
Yeah,
not
no, that's
just
important.
someone who's treating it and helping people. You've lived it and are living it still too. So I think it's helpful context.
Yeah, thank
One
you for
comment in the chat that just it says, after my injury, I felt I lost my humanity. So that's
that was the one that had come to me directly. So great. Thank you to the person
okay.
for sharing with the group. And
Well, we can go back to the kind of
mhm.
stay on our agenda, and if there's no questions, we can go to the next part if that works for you.
Okay, that sounds good. And I would love to encourage the person who wrote that comment, maybe to come on screen during the next Q&A, because I'd love to hear a little more about what you mean about humanity, um, and see if I have any thoughts on that. So thank you. I appreciate the comment. Okay, so let me try to share my screen again. Um, okay. Arash, what do you see right now?
It's doing the goofy thing that we had earlier. So it's
Oh, so
so
you
maybe
see everything.
I just see that zoomed in, with just your slides, and I think we'll try to do it the same way you did before, maybe.
I did, unfortunately.
Gotta
So
love the Zoom tech issues.
I know, right? Right now, do you see the notes and the screen?
No, no, but we just see a couple of small slides and then the very zoomed in onto the your PowerPoint kind of menu, presenter view, custom show, stuff like
Oh, oh, that's so strange. Okay, let me try one more thing.
that.
I'm going to try to share it again. Okay. How about, what do you see now?
Now we see your notes.
Okay, so that's not what I
We
want.
see your mode.
See what I see. Okay.
Yep. Yeah.
All right, let me go to this. I apologize, everybody. Zoom can be tricky sometimes. Okay. How about, let's see. Okay.
Nope. Now we just see a very small section of your. Oh, okay. It's moving.
Moving.
Uh, okay. Yeah, you're good.
Okay, so you see
You're
the
good.
discussion and question slide?
Yep, we see that. And I would say for the next Q&A, let's just not even, don't even stop screen
Yeah,
sharing. We'll just keep it
that
up.
sounds good. That
I'm
sounds
gonna,
good.
I'm gonna no, you're still spotlighted. So yeah, we're good.
Okay,
So
perfect. Thank
great.
you, everybody, for
Thank
waiting.
you.
Okay, so the field of psychology and mental health in general has traditionally focused on the negative effects of adversity to the exclusion of any positive outcomes. And there's pretty good reason for that. For most people, in most cases, negative events do tend to produce negative consequences. However, a literature on the positive sequelae of traumatic events has burgeoned over the past decade. And a shift in psychological science has moved us from a sole focus on PTSD following challenging life experiences to resilience or bouncing back from adversity. And another way to define resilience is offered by George Bonanno, who's a leading psychological science in the study of resilience. And he defines it as a stable trajectory of healthy functioning after a highly adverse event. And he did some really interesting research in 2012. He and his colleagues looked at a sample of about 230 people with spinal cord injuries over a period of 2 years after their injuries. And their depression findings are shown here, but they were quite similar to the anxiety findings. And people fell into four groups. About 13% had a pattern of high depression symptoms followed by improvement. That's the sort of slanting line, broken up line that then evens out. That's what we typically think about as recovery. 11% had a chronic high depression pattern. That's the solid line near the top of the screen, meaning they were depressed when they were injured, they were depressed 2 years later, and that didn't vary. And about 10% had this delayed pattern of symptom elevation, where they were doing pretty good for the first year, and then they got quite depressed. But the largest group, and what I'm hoping you'll pay attention to, is the one on the bottom. This was about 66%, and it showed a resilient pattern of stable, low depressive symptoms. So he wondered why, and he also looked at coping styles because he was asking what made the resilient spinal cord injured people different. And analysis of predictors showed that resilient people viewed their injuries differently. They viewed them as challenges rather than threats. And they showed greater acceptance and what was termed a fighting spirit, and I'll go into that in a sec, and less coping through social dependence and behavioral disengagement. A lot of psychobabble, what that meant was that acceptance represented the ability to make the best of life with an injury. Fighting spirit, another positive predictor, meant that people worked to find tricks to make life easier in relation to their injury. So those were the two helpful coping styles. And the two unhelpful ones were the adoption of beliefs about oneself as dependent, not interdependent, but dependent, and reducing one's effort to engage with the stressor. That's what they called behavioral disengagement. So sort of checking out. And a bunch of other research has also been done, but as with the traditional trauma research, psychological conceptions of disability have been built on a deficit-based model. And in that model, disability is seen as a wholly negative experience. In the 1980s, though, a body of research began to document that despite the difficulties of disablement, people with SCI were faring surprisingly well. In general, most people with SCI reported a high quality of life and high levels of happiness. So, for example, a study by Roxanne Silver found that the strongest emotion for almost 60% of people only 3 weeks post spinal cord injury was happiness. In another study, the majority of SCI survivors saw themselves as being better off than most people with or without a disability. And further, even among people with the highest level of spinal cord injury, those who use ventilators to breathe, 92% of high-level tetraplegics or quads were happy to be alive, contrary to the predictions of the first-line medical responders who thought that they wouldn't be happy to be alive and thus didn't want to resuscitate the injured people. And in what has been called the most famous study of happiness, when it comes to the experience of daily pleasures, things like talking to other people, watching a fun TV show, people with spinal cord injury were as happy as lottery winners and non-disabled controls. And when I replicated that study as part of my doctoral research at Harvard, and I added a group of people who'd had spinal cord injuries for an average of 20 years, they too were not less happy than lottery winners. And if you have time at the end, I'll tell you more about that research. So another shift in psychological science has moved from a focus on PTSD following challenging life experiences past resilience to PTG, or post-traumatic growth. And as defined by psychological science and seen on the slide, PTG is positive changes resulting from the psychological struggle with trauma and adversity. And it's thought that major life crises or traumas present threats to a person's fundamental assumptions about the self and the world. And the psychological struggle to cope with those threats can result in positive cognitive, emotional, and behavioral changes. And the benefits have been found to occur in 5 domains. First, perceptions of oneself can improve. Rising to a challenge reveals levels of strength and resilience previously unknown. Second, enhanced relationships with others are reported. This can look like increased intimacy and compassion, greater appreciation for and tolerance of others. Third, appreciation of life increases. People start to live each day to the fullest. Fourth, new opportunities for one's life are found. And fifth, spiritual and existential change. That is, changed priorities and philosophies towards life are found. And people report that their values change from extrinsic or external to intrinsic priorities. And in these studies of post-traumatic growth, numerous forms, just about every form of adversity has been studied, from traumatic brain injury to war and sexual assault to spinal cord injury. And in fact, cases of self-reported growth in the aftermath of traumatic events outnumber cases of psychiatric disorder or PTSD by a large margin. Only a minority of people exposed to traumatic events develop long-standing psychiatric disorders like PTSD, whereas estimates of the prevalence of growth among people who've experienced trauma tend to range from sizable minorities to majorities, up to about 80%. And specifically, when it comes to spinal cord injury, um, a majority of, in one study, a majority of the sample experienced some positive change after their injury, with the greatest change being the people reported that they discovered they were stronger than they thought they were. In another study, the SCI participants were more likely to experience strengthened family relationships and meaningful engagement in activities. And they reported that they had learned how to appreciate the little things in their lives and chose to search for possibilities in the future more so than they had. And finally, in a study of the caregivers of people with SCI, many experienced PTG, including changes in self-awareness, enhanced family cohesiveness, and feeling appreciated. And to close this section, and to add anecdotal credence to my potential positive effects of adversity slides, I wanted to leave you with an anecdote from one of my own studies of post-traumatic growth with spinal cord injury participants. And this one specifically was on the positivity effect, an effect that's been found in older adults. So during the data collection phase, I gave all my participants, who were all young adults with spinal cord injuries, a series of memory tasks for images of positive, negative, and neutral pictures. And after the memory task, participants were asked to rate how positive or negative they thought each image was. So this glass was an example of an image that's typically rated neutral. But one of the participants, a man with a C4 injury, he rated it as highly positive, like he gave it a 9 out of 9. And so afterward, out of curiosity, I asked him why. I mean, the glass isn't half full, it's not half empty, it's just empty. So why so positive? And he said, exemplifying a key result of post-traumatic growth in SCI, appreciation of the little things. Yes, but at least they have a glass. So let's shift gears a little bit and talk about identity. And I'm wondering if this is partly what the person who commented that they felt that they had lost their humanity was referring to, because identity transformation is one of the most profound effects, I would argue, following SCI. And I'll start with a photo of me before my spinal cord injury. Here it is. So in the beginning of my story, I was an athlete. And in the 16 years leading up to 1994, athletics really defined me. So I thought. And the sports seasons sort of served as divisions in my life. Like fall was for volleyball and cross country, winter was basketball, spring was track, and summer was for conditioning in order to do it all over again. And I was given a scholarship when I was 15 to compete for a private boarding college prep academy in Hawaii. So I flew over there and started school. And at the end of that year, I had competed in cross country and then competed in track for that school. And my team had just won the state track meet, and several of us were driving to the beach to celebrate. And my best friend, Tara, a hurdler, had called shotgun. So she got to sit in the front passenger seat of the car with full seat belts, lap belt, chest belt. And I'm sure you know where this is going. I had to sit in the back. And at that time, which was 31 years ago next week, the cars in Hawaii, some of them didn't have seat belts. So the driver, who was another friend of ours, was around 17. She did what many teenagers have done before, probably without consequence, And she was going down a winding mountain road and trying to pass 3 cars in a no passing zone. And she was going about 90 miles an hour when the front car turned left suddenly. We ricocheted off, hit a lava wall, and I was thrown out of the car. And I was in a coma for the next 10 days. And when I woke up, the surgeon told me that I will never walk again. And I remember I just woken up from a coma, and I have this hazy memory of hearing him and thinking and kind of smiling at him and thinking, he doesn't know me. I've got summer track practice starting in 2 weeks and then club volleyball. He obviously doesn't know my schedule. And then I fell back into the coma. Um, so after I woke up, however, and was still in the hospital some 4 months later, it really started to dawn on me that my life had changed significantly. And I went to outpatient therapy in Southern California, and I met this amazing group of role models, all of whom had spinal cord injuries and fun, beautiful lives, who traveled and went to concerts and did just about everything. And I feel so grateful today to have had those peers, because they really gave me my happiness back. And I remember in terms of identity, one of the things that was most transformational was I just didn't like how often I was being told that my life was over. I was no longer an athlete. That was that. And because that wasn't my experience. I was only 17 at the time, then 17. And so I began to internally sort of fight back the fighting spirit that I brought up in from one of those studies. And I decided to have an adventure, that my life was going to be an adventure. And I made the decision to move to every great city once. And I've now that I'm older, I've moved 31 times and lived everywhere. And I started racing a friend to get to 50 countries, and I'm at 42. Um, and I started Stanford about a year and a half after my injury. And when I was there, I always knew I wanted to be a psychologist, but my focus really changed and solidified. I wanted to study resilience, and then this new concept of post-traumatic growth, because that was more similar to what I felt like I was experiencing. And so for me, my identity shifted from uh, just being an athlete to being more of a scholar and somebody who cared a lot about service to humanity and trying to make a difference. Um, and going back to school definitely helped that. And after I graduated from Stanford, I took about 5 years off to do every adventure I could think of, traveled around the world several times, volunteered, and ended up back at Harvard, where I was able to do my own studies on happiness and on post-traumatic growth. And this is a more recent picture of me. And I put it against the themes of post-traumatic growth because I really feel like that has been my life experience, not the dismal, negative stories that I was told to expect. So with that, I would love to shift to Irash and Mia's stories.
Thank you. Thank you. Yeah, I think the section on identity is just so important. And so yeah, I'll share a little bit about my own kind of identity transformation or resolution, whatever you want to call it. And then actually we'll have Mia, who's also on our NorCal SCI board. She's going to do the same. So Shen, a lot of the things you shared a moment ago were very similar to me. So I was always an athlete as well, very much identified a lot with my bodily capabilities. I'm sure there's probably other people in this Zoom that can identify with this. I played sports growing up in my 20s after college. I decided not to get a traditional job or follow a traditional path. I took a job leading bike tours, biking and hiking tours all over the world. And so I made very little money, but I was very happy because I got to travel the world and ride my bike and show people how to travel in places, all over the place. And that was all by having a very, strong, capable body. And I identified so much of everything I did, not just the activities, but just so much of my own identity was focused on that. And so that was one. There's kind of like three elements of my identity that I think is important for this story. The second um, was music. I was never that good of a musician, but I always played music. It was a big part of my identity. It was a hobby. I played in bands when I was in high school, and again, never to the point where I thought it could be anything more than that. But it was something that I enjoyed. It was something that I came to when I was feeling down or wanted to de-stress. I'd pick up my guitar and I'd tool around, or I'd play with friends, and it was a wonderful experience. Third part of my identity was cooking and food. And I started cooking when I was 8. I had family members who influenced that quite a bit. Always loved food and kind of went in line with the body aspect too. I always was pretty healthy and felt like if I was taking the best care of my body, then my body would be good to me. And as a result, that's what it was. I never broke a bone. I never got injured. I played college sports, high school sports. And all throughout, I was cooking and feeding myself, and I loved the opportunity to do that. And so when I was injured in 2012, all of that just completely got questioned in my head. As in my head, it was, how am I ever going to be anything again? How am I ever going to be the person that was? And to keep it brief, I can't go too much into all the different elements of that, but I'll just say it took a very, very long time for me. I was not someone who, bounced back quickly in that sense. And my mental health struggles were really pretty prevalent in the first few years. So I would say the physical capability, the being an athlete, was the hardest at first because obviously when you're using a wheelchair, you don't know how you're navigating the world. That was really hard. But I did find that I loved swimming. I never swam before my injury, but I started to do it after my injury. And so over time, I got better and better with that. And it relieved my pain. It was the only cardio that I really wanted to do. So I basically reformed my athlete identity into swimming. And then the music was, unfortunately, that's one I didn't really find a way to resolve or get back. I have a C5-6 injury. I'm very lucky because I have a pretty good upper body and my arms work well, but my hands are impaired. Again, I'm lucky because I do have good function in my fingers, but not enough to play guitar. So that piece, that's been really hard to kind of to make peace with the fact that musician Arash is, at least for now, he's not here. I'm not going to say gone forever or something like that, because who knows what can happen. Um, but the third piece, the cooking, that's another thing that I retaught myself how to do. And so it was really, really enabling, actually, when I first kind of grabbed a cutting board. It was kind of like, come hell or high water, I'm going to figure this out. And I was in a kitchen. I wanted to make myself something. I didn't want someone else to make it for me. I wanted to make it the way I made it. And I just grabbed a cutting board and I put it on my lap. And then I grabbed a sharp knife, which was a little risky because my hands were even weaker then. And I just started chopping an onion because pretty much everything I made started with chopping an onion. And I just said, I'm going to try it. And over time, it got better and better. And again, like now that is something that I was able to reformulate and bring back to my identity. So I'll kind of wrap it up there. Again, this is a very complex, and we can all probably share quite a bit on this, but for me, it's those three parts. One of them, again, nothing is forever, but I've kind of made peace with it's kind of not part of my post SCI identity anymore. I'm not really a musician and I'm not going to play much music. But these other two elements are so strong and so, I feel so capable. And honestly, I think because of that mental space from the music isn't there, that mental energy has been filtered into these other two elements. So it's almost like the athletics and the cooking is even better than it was before because like that, kind of like mental energy capacity got like sent to these other two places. So that's a little bit about my identity story. So yeah.
Thanks, Arash.
Um, thank you. Thanks for letting me share, and thanks for everyone listening as well. I'm going to pass it over to our final presenter on this identity piece and introduce Mia Natalia. Mia is on the NorCal SCI board of directors and had a spinal cord injury herself. And I won't say much more. I'll pass it over to Mia. Can you share a little bit about your identity story?
Yeah, of course. Hey everyone, for those that don't know me, my name is Mia. And it's kind of crazy because earlier we heard her talk about how there's some people that have a spinal cord injury but dealt with depression before their accident. And that was me. I was actually diagnosed with depression and anxiety when I was like 16, and I had my accident when I was 20. The crazy thing is, straight out of high school, I had this crazy idea, this dream that I wanted to get into the fire service, and that's exactly what I did. I got my EMT here in Fresno, and then I moved to Northern California, Butte County, and became a firefighter. So I was a firefighter EMT for 2 years. I then transferred back to Fresno to get on with the department here, still employed, going through another fire academy. And I was almost done with the academy and I had my accident where I tumbled 50 feet off of a cliff, missed my footing, and ended up with a spinal cord injury, a mild traumatic brain injury, and so a whole lot of things going on. Now, in that whole process, the doctors told my parents that I was most likely not going to be able to make it through surgery, which obviously I did. And then after that, after surgery, the neurosurgeon came in and just like most of us on here, got that news that we're not going to be able to do what we used to be able to do. For me, that was walking. And so imagine like I had just got started in this career, worked my butt off to get on this fire crew. I'm still young. I was 20 at the time. And to have that completely stripped of me, all that work, it started to make me go down this rabbit hole of depression even more in a way that I never thought life could get worse, but it somehow started to just trickle downwards. And not only that, but I was very outdoorsy. I was this adrenaline junkie, always hiking every weekend. So for me, it was another day, but that day just took a turn. I used to be a dancer. I would always battle people at parties, breakdancing. That was just something I love to do. And I've always been like that since I was a kid, very active, hardly ever in the house. So when I got that news that I'm not gonna be able to walk again, um, I feel like in that moment, it completely stripped me of my identity, who I knew myself to be. And that was the beginning of a whole nother grieving process. It was a different type of grieving that I had to experience. And I still do. There's still times where it comes up or I don't really experience depression anymore. And I'll kind of talk a little bit more about that. But there's still times where I'm out with friends and they're all dancing and it kind of hits me of like, man, I can't just get up and just go dance with them. Like I can roll over there and I'm gonna still bust the move and go dance with strangers or whatever in my own way, but I can't walk over there and dance the way I used to be able to. So my identity still takes a hit. It's just learning how to navigate life in a way that works for you. And that was the hardest part because my 1 year anniversary, the PTSD kicked in. I went down a really dark place, intentionally put myself back in the ER from intentionally overdosing, and my dad rushed me to ER. But after treatment and everything like that, I passed a whole bunch of mental evaluations to get released. The nurse asked me a very simple question, and it kind of lit a fire in me. She asked, "Where do you work?" Now, 6 to 7 months after I was released from the hospital, I got picked up by Fresno Fire Investigations, where I was working as an arson specialist. So I went from being this firefighter, now in a wheelchair, to working in investigations. So I was still in the fire service. And I had to learn how to get back to life really fast. Started driving because I had to go to this job now. I didn't want to put that financial burden on my parents. I've always been super independent and that type of personality. So I started working. So when I had this, like, few months later, when I had my 1 year anniversary, that's when I overdosed. And when she asked me Where do you work? I don't want her to call my fire chief and say, hey, this kid you just hired is mentally unstable. And so something in me shifted, and I just knew the way that I was living wasn't living at all. I was barely existing. In fact, I didn't even want to do that, but I just beat death again. So I don't know how many chances I'm going to be given, but I have to do something different. And that was the last time I experienced depression like that. And I can tell you that depression always feels like you're stuck in this cycle and you don't see anything but that. You don't see how life can get better. You look at everyone walking along the streets and they seem so happy, like they're just filled with joy. And then you're just thinking about, why isn't my life like that? Like you get stuck in this pattern, this tunnel vision, and there's nothing else that you can see until you're out of it. And that's the hard part, the shifting. Your identity has to die in a way only to grow into a new identity. And if you think about it, we're constantly dying, not in a physical way, but all throughout our life. Our identity is constantly being stripped. We move into this next phase of life, like this identity no longer resonates. I am no longer who I used to be. Let me throw on this new identity, like this is who I am now. We're constantly doing that, going through life. We throw on these new identities like jackets, and sometimes we forget to take off the layers, and it starts to feel heavy. We start to feel stuck. But the more you strip yourself of all that you're not, you'll find who you really are underneath all of that. And that is the hardest transition to ever make. The grieving process sucks. And I didn't go to therapy and talk about my issues or anything until this past year. And I not only do talk therapy, but I also do EMDR, which was mentioned before, using the movement of the eyes, because I found that I didn't want to talk. As much as I can sit in front of somebody, it was too uncomfortable for me to talk. So we started doing these EMDR therapy sessions where my therapist would have me call forth the memory of my accident. Whatever memory popped in, whatever visual came to my mind, I had to sit with it. So I would bring it up, and then she would pull out this pointer that was like an antenna about shoulder width, and she'd be like, okay, follow the tip of the pointer back and forth. And I'm like, that's it? Like, she made me call forth that memory, and now I'm with keeping my head straight, just my eyes, following this pointer. And the more sessions we started to do, the lighter I felt, which was weird because within that 1 hour, we would do a full EMDR session and we would do different rounds. The first round would be like maybe a minute. I would call for that memory. She gave me a blanket because she said, as she was watching my body language, she can tell I was angry. So she gave me a blanket and I'm twisting the blanket, holding it in my lap, just twisting as I'm just staying quiet, but thinking about that memory. And I'm following this tracker. And by the second session, my hands eased up just a little bit. By the third one, tears started coming out. I'm like, where did those come from? So my body felt how it felt at the time of my accident, but it wasn't to put myself back into an uncomfortable position. It was to process it because my body's been holding onto that for years now. My accident was in 2017. I have a T9 spinal cord injury. And so I am going to be hitting my 8-year mark in September. So it took a while for me to want to feel ready to talk about it or to process those emotions. And so by like the 10th round, within this 1 hour, I felt so lighter that I wanted to go home and take a nap just because my body just wanted to rest finally. It's tired of being in survival. And I found that every EMDR session I do, my body feels like that. But I always feel like this baggage is just taken from me. Like I've been carrying this weight this whole time, and I finally get to just release it. So for me, the identity I realized, and I'm actually an entrepreneur, so I teach identity. I do motivational speaking nationwide. I actually teach on identity. And I found that no matter who I'm talking to, whether it's someone with a spinal cord injury, whether it's an entrepreneur, everything roots from identity. Everything. Whatever you perceive yourself to be, however you perceive yourself to be, your career, relationships, it all comes back to identity. Even your income is tied to your identity. You have certain beliefs wrapped around money based off of how you grew up. So you manage money a bit differently. It all ties into identity. That's the root of it all. So instead of focusing so much on the external world of like, man, this is all going on around me. Why I see everyone happy, but why can't I be like that? They're mirrors. Every single person that you meet in this lifetime is a reflection of you in some way, shape, or form. So whatever you see in me is a reflection of you. It's mirroring back your own energy to you. So I found that by witnessing all of these things around me, it was actually showing me parts of myself that I didn't yet identify with. And the more that I progressed on this journey, I have little by little evolved into this identity that depression no longer serves. That's no longer a part of my identity. And it's taken a while to get myself out of that, but it all comes back down as to who I know myself to be and wanting to do more, to live life a bit differently. So that's just a little bit about my story. Hopefully I didn't go on a little rant.
No, thank you so much, both of you, Mia and Arash. I could listen to you talk, Mia, forever, and Arash, next time we're having a potluck.
Yes, yes, yes. Shem, I'm going to say one more quick thing before
Yes, please do.
we go to
Please
your
do.
last section. I'm going to say this again at the end, but just in case people drop off, I just want to, I would never forgive myself if I didn't. NorCal SCI does have a grant program called Road to Recovery. And there's 4 different categories within that. One of the categories for that
You have to
grant.
raise your hand. Hold on.
It's a meter. Stop.
One of the categories that is mental health services and support. So if you are on this call, if you live in Northern California and you want to try to get some financial support for mental health, please apply to that grant. And we can help with that. So I just want everyone to know it's there. It's there for you. If you're not able to, if it's hard to go in person, you can maybe find someone who can do video. A lot of therapists speak to people over video. So anyway, I have to mention that the support is there. So anyway, I'll bring up some things again at the end, but I'm going to pass it back to you, Shen. Thanks.
All right. Thank you so much. And that is it's a perfect segue to the last part, but we're almost there. First, before we get to the very last part, which is how to access therapy or tips for doing so, I wanted to give you guys a couple of things that we can all do on our own. And they're just little changes we can make, but they've all been tested for efficacy in the lab and effectiveness in the field, all been shown to make a difference. And I've tried all of them myself, and I've found that they make a difference for me. So I wanted to share them today. It's 3 techniques. And the first of the skills is called emotion differentiation, or also called emotional granularity. And it's the skill of putting feelings into words with a high degree of specificity or a high degree of precision. And it has many benefits in stressful situations, and it transcends any single psychological problem. So you can use it for depression, for anxiety, for PTSD. But in general, the theory is that those who are better at constructing really granular, precise emotional experiences are better able to deal with distressing situations, whereas those who use less granularity, and granularity just means like specificity. It just means like, how specific are you in your emotion? Do you say someone looks happy, or do you say they look ebullient, right? Ebullient would be more granular. So anyway, so the people who use less granularity in their negative experiences are more easily overwhelmed by stress and are more susceptible to unhealthy emotion regulation strategies like binge drinking and binge eating and aggression. And this is too much to read right now, but I'm going to give Arash my slides. So if you want to go back and read through this, you definitely are welcome to. But in general, what this slide shows is that in the research, emotional granularity has been linked to improved emotion regulation and a variety of better outcomes. And it's a skill that's relevant to a wide range of psychological problems and disorders, as well as just basic greater psychological health. And a tool for this skill is this. It's the emotion wheel or the feelings wheel, because importantly, emotional granularity can be improved by training people to use more specific words for emotion. And through training that expands a person's emotion vocabulary, people can become better at differentiating their emotions and thus at regulating their emotions. So how exactly would we practice? If you take this emotion wheel, this is just one example, there's many out there. This one's available at feelingswheel.com. And it depicts simple emotional words on the inside. You see around the white circle, there's like sad, happy, I think, can't quite read it from my position. And then the next circle out, slightly more granular terms. And the final third circle is even more granular. So for example, rather than saying sad, you might say, I feel guilty, but rather than saying guilty, you might say, I feel remorseful. And that precision gives our brains better clues about how to regulate that emotion. Tool number 2, both of these last two are ways to change your body's chemistry in order to reduce extreme emotions as quickly as possible. These are two of my favorites. So the first one, you can use cold water or ice to trick your body into thinking you're diving into cold water, because that lowers the heart rate in order to increase the likelihood of survival. And you can trick your body into doing that, like when we're emotionally flooded and our sympathetic nervous system is activated and our heart rate increases. This tool allows us to decrease our heart rate and activate our parasympathetic nervous system, which is our rest and digest system, as opposed to the fight or flight system. And you can do this by either putting your face in a sink or basin of cold water, or by using little ice packs that you can keep in the freezer for when you're flooded. And you can put the ice pack, or have your caregiver put the ice pack under your eyes but above your cheekbones. And then you want to bend over forward as though you're diving into water and hold your breath for 30 seconds. It sounds a little odd, but voila, your heart rate slows and your blood goes to your brain and to your heart, and you calm down. And you have to try it to believe it. And the last one is paced breathing. And this is one that a lot of us are pretty familiar with, but it's another skill for changing our body's chemistry in order to reduce uncomfortable emotions really quickly. And it has 3 key steps. First, you breathe from your belly or from your diaphragm, because when we're under stress, we tend to breathe from our chest, which is not relaxing. So you want to move your breathing down into your belly area. And if you're able to, you can put one hand on your chest and one hand on your belly, or have your caregiver put your hand on your chest and one hand on your belly. And then you want to breathe so that the upper hand remains still while the lower hand moves in and out. And this ensures that you're breathing from the diaphragm in order for this skill to work. Second, you want to slow down the pace of your breath. So on average, we only want about 5 to 6 breaths per minute, or 1 breath every 10 to 12 seconds. And you can use your watch to record that. Look at the second hand. And finally, and this is the key, make your out breath longer than your in breath. So for example, if you're taking 12 seconds, say, for a full breath, you may want your out breath to be 7 seconds and your in breath to be 5 seconds, because this tells your brain to activate the parasympathetic nervous system and calm down. So those are 3 skills that you can try on your own. But I also wanted to end by talking a bit about finding a therapist. Obviously, as a psychologist, I'm quite biased, but I've had my own therapy as a patient and now as the clinician, and I recommend it highly. So 3 services to find therapists. Probably the most popular one is psychologytoday.com. And it has a therapist finder part that you would click on, and then it allows you to search by different topics. And it doesn't have a specific disability focus, unfortunately. I really think it should. Maybe if enough of us write and ask for it, they'll do that. But for now, some of the more useful topics that you can search by, they have chronic illness, which isn't the same as chronic disability, but it has some of the same processes involved, like a lot of medical adversity and, you know, the chronicity and all of that, high stress. So that's one. You can also search by the disorder, right? If you know you're depressed, or you know you're anxious, or you know you're suffering from PTSD, you can search by those topics. You can also search by trauma, to address the spinal cord injury. And finally, you can search by things like EMDR. Oops, I think I changed that. Let me change back. EMDR, which, like as Mia described, is a really great form of therapy for trauma, in particular because it's quite quick, meaning you won't be in EMDR therapy for years and years. You'll see gains quite quickly, or you can. The next site I wanted to point out, and this is not a typo, it's not meant to be zencare.com. It actually is .co. I think com must have been taken. And similarly, you can search by chronic illness or by trauma. They also have a loss and grief category that might be helpful. And finally, another newer therapist finder site is rula.com. That's RULA.com. And I wasn't able to look inside and see what to search by because it makes you sign up and fill it out and all of that. But I've heard good things from clients. Finally, I think the biggest barrier for folks with spinal cord injuries, or there's 2 big barriers that I keep hearing about. One is, how do I find somebody that understands spinal cord injury? That's a more pernicious problem. And there isn't a great way of looking for that right now. Rehabilitation psychologists, the type of psychologists generally that work in hospitals, are often the best bet, but they are tied to the hospital or to the veteran center. Or so once you're on the outside, sometimes it's hard to work with them. But you can search by these different topics, like I was saying. And so the second biggest obstacle that I hear about is the cost of therapy. However, there's some workarounds. And one way to start is by, if you have like insurance through your employer or through a parent or school, you can call your insurance provider and ask for a list of psychotherapists in your area. However, it's important to know that you can work with anybody in California if you're doing virtual therapy, which is what I do with my clients, where it's through a computer screen, because the mobility aspect often makes it harder to access. So, but as long as somebody is within California, they are licensed to work with you. So you can search far and wide. And for Medi-Cal, which a lot of folks have, you know, California version of Medicaid, I would recommend the same thing by calling the insurance provider and asking for a list of psychotherapists that are taking clients that have availability as a starting point. But for today, I put together this list, and it is a list. Oops, I think I'm changing it. It's a list of low-fee clinics. So what these clinics, and these are all in Northern California, and they offer a sliding scale, which is based on your income or your ability to pay. So some of them start at $0, like if you have no income. or $30 a session. And this list, I'm going to give it to Arash so that he can pass it on. But some of them are very, very good. And what a lot of them are the training clinics for doctoral level psychologists like myself. So this would be after, 4 or 5 years of training to be a psychologist. These people are getting their hours in order to get licensure, and they have a supervisor. So you kind of get 2 sets of eyes on your problem or on your case. So even though they're still in training, it's actually a really good resource. And I listed a bunch of those, like from Palo Alto University, which is a consortium with Stanford, is the first one, or actually the first 3. And there's a number of other ones, like the Wright Institute is really good as well. So finally, please feel free to contact me if you want to access the low fee list or need help finding resources. And Arash maybe can talk again about the scholarship fund that he has for help accessing mental health care, because I think that might be your best bet.
Thank you. Thank you so much. That was just such a phenomenal presentation, and I really appreciate you ending with these really kind of tangible solutions. So thank you for that. Obviously, it's something that we should all be focused on and thinking about, and it's something that continues. Even though I'm 13 years out from my injury, I'm still seeing my same therapist and continuing to get that help because God knows I need it. So anyway, yeah, in terms of the resources, again, I'll just repeat really quickly. Road to Recovery grants, that's through NorCal SCI. That can pay for mental health services. I do want to be very clear. We don't have like the list that Shen just shared is much better. I mean, we don't have like a similar list. So what we really generally ask is for folks to find their own therapist, find, someone that maybe they've already been working with them, maybe it's new, but then the grant can help pay for it. The grant is not like a one-stop shop for connecting you to the therapist that knows everything about SCI. I just want to really be clear about setting the expectations for that. But it can provide some financial support for you to do that. So if you're interested in getting that grant and you haven't gotten one already for another category, please apply for the Road to Recovery grant and choose the mental health services and, fill out the application and everything. So that resource is there for you. I also just want to make another plug for something you mentioned earlier in the presentation, but if you're thinking, doing one-on-one therapy is not feasible or not your thing, remember peer support. I think Chen, you mentioned this as well. There's lots of peer support options out there. I'm going to mention 2 other quick resources. Number 1 is on our on the NorCal SCI resources at the very top. If you just click resources and then you go to SCI meetups, there's a whole list of peer support groups. Most of them are virtual. Some of them are hybrid and meet in person and virtual. So if you want to join those, some of them are very specific to, to Spanish speakers, or there's support groups for mothers who are in wheelchair users, whatever. There's support groups elsewhere that specific for people who've suffered gunshot wounds. These resources are out there, and a lot of these are virtual. So you don't have to go anywhere. You just get on Zoom and you do it right there. So that's one other resource I wanted to share about these kind of SCI meetups on the NorCal SCI website. And then lastly, if you want a peer mentor, we have a wonderful peer mentor page. Our other board member, Trisha, has been really great putting this together. We have over 20 peer mentors. These are people who've had spinal cord injuries themselves, all different levels, types of injuries, ages, everything. So we have their profiles there. So you can look on that page. And if you want to just maybe talk to someone has been through it and can maybe share a little bit about what they've done to help them get through and help them with you. They are trained either through the Reeve Foundation Peer Mentor Program or the United Spinal Foundation, or excuse me, United Spinal Peer Mentor Program. So everyone on that page is there. So you doesn't just have to be like a one size fits all kind of thing. There's the meetups, there's virtual, there's in person, there's peer mentors you can talk to one-on-one. So please make use of these resources. Don't let your mental health suffer unnecessarily. So we did really good sticking to time. And I'm gonna stop here. Shen, I think you said earlier, I can share the slides and some of these resources with everyone here. So I will do that. If you are on this call or if you signed up, you will receive those. We also recorded this presentation, so we're going to post this on the NorCal SCI YouTube page. So if you know someone who wasn't able to be here today and you want to share that with them, I made the mistake. I think I missed the first 60 seconds or so. I didn't record, so forgive me for that. But we got everything else, which is really all that matters. So, so please pass along that resource. We'll kind of get the word out as well. Shen, I know we're a little past time. Are you able to stay on for just a few minutes if there's any burning questions that folks have? Because I know there might be something. So I'll stop talking now. But again, thank you everyone for coming. We'll stay on for another couple minutes and take any other questions or comments that folks might have.
Hi, this is Steve.
Great, go ahead, Steve.
Yeah, I thought I was doing pretty well. Surprisingly, this presentation makes me feel worse because it's like I have nothing. I'm a quadriplegic. I can't even move my arms or hands. I was also an athlete. Yeah, I did, over 6,000 miles of biking and 1,000 miles of hiking a year. And I wanted to say that it's wonderful to see how well you three are doing, but it's like I've lost everything. I can't feed myself. I can't, get out of the house, much because I, need a paratransit. And plus I suffer from unstable blood pressure. So, I think your examples are very inspiring and wonderful, but it makes me, I'm trying to do with what little I have. About the only thing I do is I look at my iPad, I read, I stream, and, getting out of the house, hearing about all this traveling. I wish there was some way to do it. I don't even know how it could ever be possible because I have a trouble just getting to. I haven't been to a grocery store. Every hopefully 1 week I go out for a meal, but with my wife. But even that doesn't always happen. So I feel like I want to move on, and I want to. If I had my hands, the first thing I thought, well, that's nice. I could easily do some arm aerobic exercises, and that would help. But I can't. So I saw the FES presentation. I'm hoping maybe that might do something, but I haven't been able to access those kind of things yet. And I don't know if I'll be able to do them even when I do. So it seems like the three of you have a lot of resources because you're all still able to use your arms. And I not only can't use my arms, I can't move at all. It's like I'm in a straitjacket. So I'm trying to make the best of what I have, but I do feel sad, and I try to find pleasure, enjoyment. Like I'm enjoying watching the Golden State Warriors, and so for me, enjoyment comes down to just looking at things that I enjoy watching or reading on my iPad. I'm totally dependent, and I don't know what more I can do. And so when I see how well you're doing, it's like my thought is, well, that's nice, but what can I do? I'd love to be able to find some alternative stuff to do. We're talking about maybe getting a wheelchair van, but they're very expensive, and not sure my family will go along with it. And talking about maybe if the FES bike goes well, getting one of those if it goes well. But again, there's a cost, thing. And the trouble is, we're not really that poor. It's just that I require 24/7 care. It's costing us like $630 a day, and so the money will drain fast. So I feel like I'm sort of trapped. And any help you or thoughts you could provide, I really would appreciate it.
Thank you, Steve, for being vulnerable and sharing all of that. And that is, I'm doing a mental database list of all the people I want to introduce you to. Unfortunately, some have passed because what you've said is so similar to what a lot of higher injury folks have said. What's your level?
C1 to C4.
Okay. Yeah. Some of my close friends actually, or one of them was, I think he was C3, C4, Alan. He actually used to live in this area, but he passed. And anyway, the point is, I have a lot of friends and acquaintances who have very high injuries, and yet they've carved out these lives that have joy and have connection to others and, adventure in whatever form they can. And one of my friends from Harvard, he has a very high injury. I don't recall his level, but he travels. And you know what really changed things for me was meeting people with a similar level as me, because it meant they had similar function,
Yeah,
and asking them for the tips and techniques that got them through the day.
yeah,
And everybody, it seems like, have discovered something to bring joy into their lives.
yeah,
And so I really, really, I 100% believe that it's possible for you too. I
yeah.
wonder, are you connected at all with the peer support network?
Well, I had a mentor I got from the list that I requested, and then another one that I was connected up with named Chris. But it's like I talked to Chris once for 15 minutes. He gave me his advice. His advice was twofold. One, get a van. Two, don't burn out your caregiver. But there was no sense that there be any continuation. Sense, I sent him a message. He never responded back. And so, I think he still works full time. He's younger. So the sense I got was, here's some quick advice, but I don't really have the time for you. And then there was another one. You remember what his name was? One who lived in Fremont, yeah.
No.
There was another one who lived in Fremont, where I live, and I had sent a message to the person who is in charge of that program. My wife has gone to the caregiver group, and she got it, and I never heard from him either. So, I've reached out, but haven't gotten anywhere. And I'm just, I think that I'm coping pretty well, given the limitations. I look at some of those, I feel sad, but I never would have called myself depressed. I have some of those symptoms, but I try as best I can to find pleasure. So food still gives me, pleasure. Watching, the Golden State Warriors gives me, pleasure. Reading gives me pleasure, and going out to eat somewhere gives me more pleasure. But it's after doing the same things over and over and over and over and over again. I feel like I want more out of life than that. My passions were hiking, biking, skiing, and traveling. And I did, bike tours in Italy, New Zealand, Oregon, Washington, Arizona, California, and now I 5 years ago I climbed to the top of Mount Whitney. That was one of my things, and then at the top of Half Dome. Those were some of my goals in life. And so
That's
I've
amazing.
lost. Well,
Wow. I'm really impressed. And I can
yeah,
tell that that same spirit that you, grappled with and wrangled to get you up those mountains and on all those bike trips, right? That's
yeah.
the same spirit that you have now to fight this. This is
I'm a
just,
fighter. I
yeah,
really am.
you are a fighter.
I just,
Absolutely.
I just need some tools to help me
Yes,
fight because
yes.
there's so little
It's hard.
of it. I'm just, I'm trying. I'm not
You
giving
are.
up, but I'm trying.
I know you're here, right? That's a step in the right direction. And I'm wondering, Steve, do you have a therapist? Because I think we should find you one if you don't. Because I think you have a lot to say,
Yeah.
a lot to process.
Well, I'm a Kaiser member, so I would have to keep it within Kaiser because it's paid for. Our income is such that we'll never qualify for any of the freebies. So what I need is to find somebody in Kaiser who maybe has some experience and empathy with someone like me.
I think that's definitely worth starting. I trained at Kaiser for
Yeah,
1 year. And the thing about Kaiser is they have a group-based model. So they like to put people in groups, which might actually be kind of helpful to have the
yeah,
socialization and peer support.
yeah,
You can go outside of Kaiser. You do a single case agreement with a therapist who's
oh,
non-Kaiser. Um,
my eyes the
Tell
other
you more
and
about that if
shaking.
you want to have your wife or if you want to email me. I can tell
Yeah,
you more about how to approach the Kaiser situation because it
yeah,
can be a little tricky.
yeah. I think you know the group might be good, but I think maybe one-on-one would be good too. So
That's his goal.
if they have any one, that
Mhm.
oh,
Let's make that connection,
Yeah.
maybe
Yeah.
offline, and I just want to make sure um, you can do that. It sounds like there's some resources that might help,
Absolutely.
Steve, and appreciate you sharing. I just want to know
yeah.
before we wrap and make sure if there's any other questions or folks who wanted to.
My left eye again. It was 13.
Are there any other questions or comments or?
That was pretty much.
Well, I think we can maybe leave it there, Shen. Is that
Okay.
works for you? So again, can't thank you enough for sharing this with us, for planning this session. Thank you everyone who joined.
Yeah.
Um,
Thank you.
Again, mental health, it's so important. We all have our experiences with it and different ways of coping and figuring it out or not figuring it out, and we're all on this journey. So again, thanks for joining. We will make the video available online, and we might do another session or something like this again in the future, right, Shen? We've had these conversations. So let us know if you have feedback, if you have ideas, or if there's things you want. If we did another webinar like this again, you can email me, rash@norcalsci.org. We're not very hard to find, so you know how to reach us here at NorCal SCI. But let us know if you would want to do another session, something specific you want us to explore, another topic. And I can work with Shen and others possibly on doing something again. So we don't want this to be a one and done kind of thing because mental health is not a one and done kind of thing, I think. So thank you again, everybody. Appreciate it. Thank you, Shen. Thank you, Mia, for sharing your story as well. And we're going to sign off and have a wonderful evening, and we'll all be in touch. Take care of your mental health, everybody.